Good evening, everyone. And I know all of us are literally sitting on ticking time bomb these days, especially about the COVID-19 pandemic. Probably the generation which is attending today's program might be this the first pandemic which we are seeing. Yet probably we don't want to see any more after this, probably. But having said that, somewhere we know about the history, how it started and all. Started somewhere in the last week of December. First reported at China to Wuhan province. In fact, we have one of our faculty member, Dr. Peng from Wuhan, so he should be able to share his own clinical experience. The question is, it has started through there, it went to different countries and across different continents and all, showed its manifestation affecting some country pretty seriously initially and subsequently slowing down. Some countries affecting late and hitting it very hard, those countries. And every country is going through its own correction modalities and all those things. But in the process, there has been a huge, I should say, social and life loss and also economic loss, which is incomprehensible. All our mankind has not seen. Probably, I would like to say the only one group of probably the things on this earth. Probably they are enjoying this particular period. Seems to be the nature and its probably the birds and probably the animals and probably in the forest and whatever you say, but sea and all, because they are all lively and all because there is no human interference. But having said that, we had done our own best thing, whatever was possible for the globe and all those things, pollution and wake up call for all of us, Pauline, water we might have damage the ecosystem in the nature, because after the lockdown, a lot of things have improved. That's on the one side of the story, but other side of the story, the lockdown cannot be permanent. It was only to make sure that the countries develop enough infrastructure or probably resources so that subsequently they can take up probably the reconstructive work of the healthcare system and all, and probably take care of people so that the impact of the pandemic can be reduced. Now many countries are coming out of the pandemic slowly, and as they're coming pandemic lockdown, slowly the numbers are increasing. So now nobody knows how long it will go on, what will go on, and especially for the president who are probably today will be focusing predominantly on my colleagues from the Department of Anesthesia across the globe. I just wanted to share my thought. How will be our clinical practice following the COVID-19 pandemic? Will it be same or will it be different? And before we discuss about all these things, we need to have a little bit about the historical perspectives. So in this context, probably today's discussion seems to be quite interesting, and hopefully it will be productive, and probably we can learn from each other much more than what probably we can learn alone. I have a disclaimer here that no conflict of interest as far as the today's presentation, I think of that concern. Today, I'll be discussing with you about the epidemiological factors about the pandemics and all those things, how each pandemic has behaved over so many years, or probably over so many centuries. It's very important. Unless you know about the historical perspective of the problem, what you're handling, you will not be able to get at the grassroots level. Then we'll speak about the COVID-19, that's a current the issue, that's a pandemic which is going on, how to come out of it and how long this can last, and what are the solutions, how do we go from here. And most important is what is our current clinical practice, what we were doing before the COVID-19 hit us. And then we look at the challenges it might bring it along with it, because we need to modify our way of handling things. It may not be the same what it was earlier. And even to handle those challenges and all those things, we require some resources. We already have some resources and all those things. Here, probably we'll have the SWOT analysis. That is nothing but about what are the strengths, what are weaknesses, and what are the opportunities, and what are the threats. Of course, subsequently, we need to speak about the future. Are you going to continue like this, and how long will you go to that? If any more epidemic comes, should we prepare ourselves? The last but not least, let's not forget, these days we are hearing, we will ask maybe in a couple of weeks, and also the second wave, especially we are hearing from China and then South Korea. In this context, today this is very important. It's not about the current pandemic what we have to plan. In case we are going to hit by the second wave also, we should be ready. We should take care of not only our own patients and probably the nation and all those things, but most important is you'll have to take care of your family, which is the primary important, because without them, we are nothing. It's important to know about the previous pandemics, what all have hit the globe in so many years and all. I think now the bubonic plague happens to be having the highest number of episodes, major pandemics across the globe over the last 2000 years. And the major things which probably current the human civilization can remember is one happened sometime around 6th century, and the second one probably around the medieval period. It was about 14th century. Then we had in the 19th century somewhere, maybe around 1855 onwards and all. The 14th century was somewhere in the during medieval period, and 19th century again happened to be the happens to start in China and all those things. But question here is nobody knows how it disappeared sporadically, because if you go back to the historical perspective, how this pandemic ended, you can just listen to that one. Like, there were episodes where there were I should say the people had the lymph glands engulfed under the groin, or for that matter under the axial and all those things. People just collapsed. Just we keep hearing, but subsequently there was little bit we had information about 1855 and onwards and all, because by then it was realized that rats were one of the major culprits for this kind of pandemic, and then they realized that subsequently it's not the black rats which are responsible; it was the brown rats, and that's once they were eliminated, most of things got eliminated. But even to this stage, it has not made a complete exit from the face of the earth. The plague keeps on happening in sporadic foci here and there, sometimes in US, sometimes some other part of the world and all. It has been happening, but definitely it's under control. It has not achieved probably the whatever the magnitude achieved at earlier point of time. So let's see. I hope it keeps a low profile as long as we can remember. The next major pandemic which we can never forget is the smallpox. It was there for almost for 3,000 years. Almost every civilization on this earth has recorded the episodes of smallpox at various times and all those things. But there also we took quite some time for us to understand what was happening and all. We thought about maybe black sporadically that date and all. Finally, somewhere maybe in the late part of 19th century, realized it was come from the variola minor, that virus. And because there was no animal host, I repeat, because there was no animal host, and the infection was obvious on the face of the person. So because the quarantine was very easy, it was not like current flu pandemic, what you have where you cannot make it. There could be somebody who's asymptomatic carrier. That kind of thing was very less with smallpox, and almost we lost probably, at least from Indian point of view, we lost almost close to 2 crore people for the same smallpox over years. The quarantine was easy, and of course we had the vaccine then which was for the lifetime cure, and that's how we could escape from the smallpox pandemic. Then we had the flu pandemic of 1918. That is at the end of the First World War. It started, and all people didn't never realize that it almost killed 50 to 100 million people, and over 2 to 3 years, and people didn't know what was happening. Like especially the young sailors, the young soldiers, just coming and just dead dropping in the hospital or where the war was happening, and all. Nobody knew what was happening. They thought it was just happening like that. But subsequently, luckily for the mankind, it faded as a benign flu over next 2 to 3 years, and it disappeared. Now also it comes now and while. It comes like probably a benign common cold, or maybe something a little bit more than that, and then disappears. Then we had our own local endemic thing, which threatened to become pandemic, but which did not achieve that kind of capacity. One was the Hong Kong flu of 1960s, and then we had the SARS somewhere in 2003. Then we had the Ebola, the endemicity. We thought it might become pandemic. Luckily, it got contained and all those things. So if you just know about the history of the pandemic, the biggest problem is, as I told earlier, this kind of pandemic, none of the current living like human beings have faced the pandemic so many years and all those things. We are seeing, but it actually got quieted. But this is something different and all those things. So the current pandemic, what we have the COVID-19, like we heard about the history, like historical aspect of what happened with the bubonic plague and what happened with the smallpox, and subsequently what happened with the SARS, and then happened with the Ebola, then Hong Kong flu and the influenza of 1918 and all. Now the current generation is facing the COVID-19 probably, which none of us we are mentally prepared. Anything like it just started like the somewhere reported first time December 2019, and within no time, in just about 4 months of time now, this is statistics as of today. It's 13th of May 2020. As per today's statistics, almost about as you can see, 4.3 million people are affected, and 1.6 million people are recovered, and 2,93,000 people have lost their life. And we don't see an end to this one. We don't see an end. And it's just going on. Almost all continents are affected. Probably I can say about Antarctica is one thing which is not affected. I'm not sure about Arctic and all. But yes, some of the countries which are not affected, which is very important, like handful of countries, especially in the Pacific Ocean, they are not affected much about this. They're not at all seems to affect as per my information was what is keeping track of the pandemic across the globe. Somehow they escaped under, we want them to be away from all these things because who's affected, let's face it. So as I can see, the whole world is stuck. It's locked down. We are stuck. We don't know how to go from here. Should we start opening it or should we stop at this stage? Lockdown cannot be permanent, I told you. If you lock down, probably instead of dying with the pandemic, you might die with hunger. So in this kind of dilemma, when we might have to open up, I should say what are the what lockdown we have and all, it's the biggest difficulty. There is no specific treatment. But if you're asking about the previous pandemic, there are no specific treatment when we had the first few epidemics. You take it of a smallpox, you take it as the influenza or a 1918, or for the matter plague and all. We never had any kind of, I should say, the specific treatment. So the mankind had to go through it. As I told, social and economic damage is unimaginable. We are now looking at restarting the economy, even though we know very well we have not addressed the problem completely. So there are going to be challenges. And when we are thinking that, okay, maybe we are ready to the challenges by going through lockdown, where we slowed down the pandemic to a certain extent, where it's become much more manageable because we're able to double up the resources and all those things, reset and all those things. Now we hear from China and South Korea about a second wave. That means we have to be ready for that also. That means it's not an easy game that it came and it left. No, it's going to stay with us, and probably we'll have to learn to live with it till we find an answer. And the commonest thing is, which people keep on asking is, how will this pandemic end? If somebody knows the answer for this particular thing, then probably I would like to say probably they'll be the greatest person on this earth. I would like to at this point of time. No, nobody knows about it. We really don't know because the takeoff was from the virus, right? Whatever it wanted to do, whichever it wanted to, and it is maintaining its own ecosystem by whatever mutation, whatever needs to be done, and the landing will be by the virus. And how it is going to do? Yes, as a passenger in the flight, if you have probably develop a mechanism or probably a vaccine or medication where you can slow down the aircraft in which you are in and you can make a safe landing, nothing like it. Though attempts are being made, but we really don't know how it is going to come in what form and all those things. It's going to come as at the end of the day, we are going to see that kind of situation. Also, we are not sure. Let us see how it might end. Possibilities. I am not saying that it is the possible. We can only deduce from the previous pandemics what it is there. The virus what we are handling right now is happens to be SARS-CoV-2. When will COVID-19 pandemic end? It's $1 billion question. None of us can answer. Most important, will it be safe landing or messy affair? Is it something like no? Probably by the end of the year, we are going to have the required medication, or it's going to be a crash landing that we are going to lose more lives, and it's going to be a messy affair. One way of best and safest way of probably the landing is incidence of infection, death rate plummeting its number, and finally it needs to be like innocuous or like an insignificant, almost negligible kind of thing, and probably we might have a safe landing. The other way which has happened with many pandemics, especially it happened with the plague and all those things in those days, Italy and all those things, and they felt that anyway they are going to do anyway, so they kept on enjoying their life, having all the nightlife, whatever drinks they wanted to have, whatever they wanted to enjoy. They thought this is the end of the world and they wanted. So once the fear about the pandemic disappears, we are seeing some part of it here and there. People are protesting, no more lockdown. We just want to come on the street. You can't just keep us in the house for this long time and all those things. We keep seeing people breaking out of the whatever way they have been confined. And this is one of the biggest lockdown heard in the history of the world. And people might be tired of the panic mode. How long you have to be tender hooks? Like I see today, like 10 cases in my neighborhood. And probably the previous street there are about 5 cases, and my neighborhood has 1 case. And probably the country suddenly had about 10,000 cases. This panic mode it puts pressure on the mankind. At the end of the man, we should understand the human reaction for this thing, and probably he'll make an adjustment. Let me learn to live with the disease. Let it happen. Whatever has to happen. The question here is, how do the challenge we can manage these things? The challenge is here, how do we manage these things till that time, till we can find a vaccine or for medication, or if we are lucky enough, the virus like mutates into a benign variety and disappears from the globe, or becomes a not so great challenge, or like in spark, like it might just disappear like that, or maybe it will some focus here and there where we can handle. Again, we don't have an answer for this one. The very fact that we don't have an answer says that we have more than 14,000 papers over last 4 months just on COVID-19. More than 14,000 papers last 4 months. Very fact that what they're seeing, what they're observing, they're just reporting, and every paper throws a new challenge, a new idea. Initially, we thought only it will spread by the respiratory thing. Subsequently, somebody said it viremia can be there. It might just come from the whatever the abdominal surgeries you might do. And subsequently, somebody says there could be a placenta transfer of some reports. And somebody said we saw it in the urine, and somebody said we saw it in semen. We really don't know. So many things are being reported, all those things. 4 months is too short a time to report so many things. But yes, one thing is that it's in front of us. We have to tackle it. How we are going to do it, how we are going to make it a safe journey, it's in our hands. As well, how do we go about it? In that context, let's look at the current, probably I should say the clinical practice, what we have in our hand. So this is from an anesthetic point of view, I would like to say, I'm just limiting to one specialty because it's very important, because if we touch the whole medical fraternity, we'll be lost because there is so many branches are there and we really don't know. Just think about your own as an anesthesiologist, what are the areas you might have to take care wherever you might be, your help might require. One with the reception or waiting area, where probably you're going to have your patients who might be like prospective customers for the surgery or for the pre-surgery consultation or for the pain clinic. As per the work what you're doing, that's one area. Then you've got a consulting office where you're going to examine the patient or probably collect information, and then whatever questions you want to ask, review the reports and all. Subsequently, you'll come to the operation theater for the planned procedure for the anesthetic work and all. Then you have to go to the patient to post-intensive care unit. Then if needed, maybe critical care unit, emergency room, the transportation. Last but not the least, let's not forget, at the end of the day, when you finish your work, you'll go back to your home, your family. Definitely, that's what we aim for. I mean, how do we handle all these things? Will our clinical practice change to make sure that not only you are safe, people around you are also safe, your patient is safe, and of course, the family is safe. In this context, let's see what are the different challenges that might be thrown at us, and what are the options we have, how we can go about it, how to turn around the things. Look at the challenges. As the pandemic progresses, many asymptomatic individuals may present for anesthesia. That's what, the other day I was reading the report from, of course, our own country, that's India, is that almost 60% of our patients are asymptomatic. So asymptomatic, but they might be carrying infection, and maybe they might be spreading the infection to other people who are more prone or vulnerable. The incubation period, what is being said is it's 1 to 14 days. It varies from person to person, region to region. And many countries, whether it's in developed countries or developing countries, there are insufficient kits, and even some kits are there. There could be the false negative test up to 30%. That's what is being claimed. And there are, of course, I should say, doctors with comorbidities, especially in anesthesia fraternity, the senior doctors who are there. Hospital, I think probably at least many people might be having some kind of comorbid, like maybe diabetes mellitus or hypertension, ischemic heart disease, so on and so forth. There will be a risk doing definitely airway care and intubation or extubation, whichever you are going to say. Transmission can definitely occur at that time. In this point of time, how do you go about it? The worst thing that can follow is anesthetists with mild undiagnosed COVID-19 infections might transmit to their patient. That's the worst thing. Imagine anesthetists with mild undiagnosed COVID-19 infection might transmit. If not anesthetists, maybe the other healthcare person working in the operating room might be undiagnosed COVID-19 infection. They might transmit to their patient. That means it's both sides, from the patients to the doctors and the healthcare person to the patient. And as per the worldwide whatever report, what we're seeing, the mortality in the healthcare professionals is much higher compared to the mortality compared to the the common civilians. So that's what we have to keep in mind. So what are the resources we have in our hand at this stage so that we can make our clinical practice more safe, not only for ourselves, for everyone around us? Safe distancing, yes, one thing we have accepted so far is because of the aerosol and all those things. Safe distancing, at least not less than a meter, that's what we keep on discussing. And hand sanitization, of course, simple to definitely adopt, like a distancing and hand sanitation doesn't require any extra cost and all. And that is going to become way of our life. Safe distancing, hand sanitation going way of our life, and henceforth. And that's so That's a change what we can accept within our own people and all those things, and across the globe, it's going to be there forever. Looks like that. And especially PPE, that's like, personal protection equipment, whatever you would like to use, whether you talk of the masks, you talk about the coverall, you talk about the shoes, or whether you talk about the goggles, or maybe face shield, or whatever you talk about, and all those things. And then, of course, we have the safe donning and doffing. We has to be taught to all the healthcare personnel who are involved. The face shield goggles are going to say these are the things what we have. The mask, we have triple layer mask and N95 mask. Triple layer mask, I would like to say not to underestimate triple layer mask for simple reason. It's quite water resistant and quite useful for many areas where you may not see the active patient, just more of an where you're doing surveillance kind of thing. It's quite useful. Gloves, you got nitrile and the latex varieties. Latex, the problem is about allergy and all those things. Again, nitrile variety might be a bit difficult to get it, but you can get it over the course of time. Then you're going to have the coverall on gowns, and then overall gowns, shoe covers, and of course, sometimes some areas where you got only gowns but not the cover or head cover. One commonly observed situation across the globe happens to be that the shortage of PPE kit for all the healthcare professionals and has been observed across the globe. And often it is seen people who are not in healthcare industry managing the patient, they are having all coverall compared to the people who are really handling this patient. So this is going to be most of the countries have increased the production in the personal protective equipment. It might take some time before we can really realize, we can decide about how exactly we can go about it. Definitely, every country is trying to gear up to local requirements, what is being needed. So let's look at some of the areas. What kind of category, like reception or waiting area for the patient before he goes to clearance checkup, we can put them under moderate risk category. We can suggest N95 mask for definitely directly dealing with the patients, and the 3-ply mask, people who are just guiding them to reach the place and all, they can manage the 3-ply mask. The gloves are mandatory, very important, because you never know the files what they might be carrying, and for the wheelchair what they might be, you never know what contamination that might be there. The gloves very important, safe distancing, and of course the patient also feel little bit insecure because this situation was not there 4 months back when he came for the first time for the investigational tests and all of the consultation. Suddenly, the elderly person who came for policy ABG, his anxiety goes up much higher because suddenly he sees everybody, or he or she sees everybody like donned in all those things. Like it looks like more like a spacesuit kind of thing and all. She can't see the doctor, and probably the golden word what is said Hippocrates oath, that is the healing by personal touch. I repeat, healing by personal touch. When the personal touch becomes a taboo, then you know what exactly the healing definition of that. Probably, if we continue at this rate for next generation, take Hippocratic oath, they'll never understand what is called healing touch, healing by personal touch. So that's irony. What I would like to say, but things might change. But fine. The vitals recording might become artificial intelligence based, because what I can see is now the thermometer might go out of circuit in major hospital because it will be more of thermal imaging what it is, and same things about the vitals monitoring with respect to your pulse rate, respiratory rate, and for that matter blood pressure and all those things. And it might be based on quality, you might get a recording. Telemedicine is here to stay, especially for they have to come for the procedure and all.
Sir, can you hear me? Hello, this is Deepesh.
Some of the question at home, if they're educated enough. It depends on which kind of physical status and all. If it's possible, you will take help of telemedicine to fill a formality and ask them at the hospital. So the area of what we take reception waiting area is a moderate risk area, and definitely we expect, especially people who are handling the patient, should be wearing the N95 mask. And of course, the 3-ply mask can be used by people who are guiding the who are guiding other people to about the destination and all. Gloves are mandatory distant because people might be carrying the files and all the wheelchair is possible. This at least I would like to, this thing should be for at least for next 6 months, if not more than that, at least 6 months. Safe distancing, we talked about a meter distance is most important thing, but there could be insecure feeling for patients, especially the senior citizens who were carrying masks and the gloves and all. Because there was something called Hippocratic oath, which said, healing by personal touch. The touch thing goes up from here. That's most important thing what I would like to say. He is not visible and probably he's not reaching that comfortably what he was. So that's one thing we have to mentally be ready for that one. The vitals can be AI based, that's artificial intelligence based. Almost the thermal temperature checking will be taken care by probably the thermal sensors and probably the pulse, respiration, and for that matter, blood pressure and all those things might be taken care by some of the AI based technologies and all the parameters what can be measured by the water monitoring system. It can change. Telemedicine is here to stay. That's very important because most of the patients who might come for the proposed surgery or something like that, and they might be looking at different things for the consultation, follow-up consultation. They would like to have the telemedicine consultation. Doctor, especially routine patients who wanted to come for the follow-up, like can I change my happiness in the hospital? So telemedicine is going to be here and it's going to stay here. And possibly, if you just look at about the consultation office, again, it's a moderate risk under where the doctor might be sitting. You'll have to wear the N95 mask and gloves and probably frequent sanitation because as the patient, probably you may not be able to see 3 to 4 patients, not more than that in per hour because there need to be a time for the cleaning and all those things. Of course, we should not be doing any aerosol generating procedure at this point of time. But most important is you might have to restrict the visitors and attendants because that's one thing. Maybe Magic at one attender, but he should be again low risk kind of profile with a triple layer mask. And of course, he should be following the hand hygiene. I don't know, most difficult thing, the COVID-19 testing because worldwide biggest. If you're asking like the way you're asking for the HIV and HBsAg for viral marker testing and all, if you want to ask for the COVID-19 testing, many countries may not have the required kits. But even if you required kits also, there could be false negative also. We'll discuss it about probably as we move further from here. It's very important for us to understand how we can go from here. Operating room, most of people had their own webinars and all those things. I don't need to tell you about that one. The safety of healthcare personnel is most important. Train all the healthcare personnel about infection control policies, what is required. You need a dedicated area for donning and doffing, especially for handling the COVID-19 patients. The mock donning and doffing drill has to be done. The role of observer is very important, who has to make sure that you have done a good donning or doffing. The plan for the procedure, regional anesthesia, and same thing communicated with everyone. The preferred choice of anesthetic work should be regional anesthesia, not the anesthesia, if possible. But where general anesthesia required, it's important to go regional anesthesia and minimum number of people in the operating room. The most important thing is what you should be understanding is, we'll discuss about it when we are ready for elective surgery and all. We'll have 2 groups of people. One, whatever the RT-PCR test what we are doing, polymerase chain reaction test, people who are positive, they will go for the treatment aspect, whatever finish the quarantine, they come back for surgery later. People who are negative RT-PCR will go for surgery. But there are many countries where the tests are not, kits are not available for different reasons because they're not having enough kits for people affected with pandemic itself. So it's going to be gray zone for some time. In case you have an emergency case, something like that, but you don't have kits and all, you will have to have all PPE precaution, full complement set, and you have to go for the emergency even if you don't have the test at this particular point of time. So these are the aerosol generating procedures which might happen in the operating room, especially for if you're going to go for general anesthetic as such. Most important, pre-oxygenate the patient for 5 minutes, the face mask and for circuit, what you have with the HME filter, which is the viral filter again. Check the anesthesia workstation and get full PPE for anesthesia, especially if you're having a suspect COVID patient, but you don't have a test to do it and all, or probably somebody who is symptoms are like but was test negative. And the communication, probably because once you're fully down, communication might be poor because of the sound getting filtered. You might have a phone, probably if the hospital has phone, fine. Otherwise, probably somebody will have to have the phone covered in the plastic cover and all. Need to use the standard monitoring, like with respect to pulse rate, respiration, or maybe blood pressure, what you are doing regularly, venous access, and whatever the suction, what you need to do because there could be the aspiration, something like that. Plan for rapid sequence induction because the most experienced person should be intubating the patient. Reason being, the more attempts you take, more amount of aerosol get generated. Probably other person can get affected. You should be using the face shield as much as possible, and there are some intubation masks or probably some the sheets which are being used. You can try those things. If manual ventilation is required, please always use the small tidal volume. Don't use the large tidal volume. It's best to intubate with video laryngoscope because you can see the structure directly, but avoid the fibrative bronchoscope as much as possible because that again induces more aerosol and whole actually theater staff gets exposed. Once you secure the airway, clamp the tube, connect the HME filter, connect the circuit, check air entry, one more HME between the expiratory limb of circuit and maybe worst station you need to connect. Institute the mechanical ventilation, stabilize the patient, and then avoid the high flow nasal oxygen. If some other cases where you might do CPAP, BiPAP, all these things you're already aware. I know about that one because by now you must have been having a good number of webinars as such. After surgery, try to extubate the patient in the operating room as much as possible, shift them to a PSU. And all area equipment should be decontaminated and disinfected according to the hospital protocols. And the bin containing the dirt equipment should be safely disposed. Thorough surface cleaning of operating room needs to be done. Doffing should be done in the designated area. Definitely take care not to touch face and hair before washing hands. Practice the hand hygiene before and after the procedure. Make it a habit. Sometimes you might be asked to transfer a known or suspected COVID-19 patient to some other areas, maybe for investigation. Transfer only for procedure studies, essential for the patient's improvement. The HEPA filter should be inserted at tracheal tube or Y-piece. Patients who are not ventilated should wear a surgical mask. One person should wear the appropriate PPE, and if could, idle accompanying person member do not have to wear PPE, but because he'll have to handle the other local things which might be required to help him in moving that area. There are suggestions for changing in COVID-19 operation theatre. Some institutions, they want to go for separate theatre because the pandemic is going to last for 2 to 3 years. They want to make it a separate block, utilize it as such so that they can limit the exposure to healthcare person. Air conditioning system, there has been discussion about whether to have the negative one or the normal pressure kind of thing. About the central suction kind of thing, because again suction fits has to come back and all those contamination scavenging system, a lot of work is being done. Things people are exploring and doing research on that one. Most important, we have defined the flow of patient transfer within the hospital. The laparoscope procedures are known to have a big spread of the viral and the load in the I should say procedural room. We need to be careful about that one. Wherever possible, the recommendation currently has been like open procedure type of laparoscopy. But newer paper, they say you can still go for it. Most of the body fluids are contaminated. That's why they're not encouraging even the autopsy and other things. We need to be careful about the waste of disposal of waste. Very important at this stage, because that's one thing neglected again can become like an endemicity in that particular area. So to conclude, I would like to say you need to know when to start elective surgeries. That a lot depends on the local authorities when they feel the number of the patient load is coming down, and resources like whether you have enough ICU beds at your place which can take it if required, and personal protection equipment are really fully equipped and personal or safe, and do you have the COVID-19 testing if required is one more thing. The priority, which kind of surgery do you want to go for, transplant, cardiac things beforehand rather than thinking of other things. And there are 5 peri-operative phases, very clear. That is pre-operative phase, that's patient clearance checkup. Then immediate pre-operative, this all discussed by the ASA. Immediate peri-operative phase where you might have to repeat the COVID test again if required. And the data, and then subsequent intra-op, then post-op, and subsequent follow-up. The data what you obtain, you might have to share with your country. Then we have to get prepared for second wave and how it is going to come. We don't know, but our plan will not change much. And safety is important. In between, if we get some medication which can help in controlling the pandemic or probably vaccination, that might make our life much comfortable. And a lot of ifs and buts, but these are the initial thoughts I just had. I just wanted to share with all of you. And you're most welcome to give your own suggestion, thoughts. And the only way to improve ourselves is taking input from others. With these few words, I would like to stop at this stage. And thank you one and all.